Good morning, guys. It's nice to see you guys. Feels like it's been a really long time since I gave a lecture. But it's nice to see the interns here. I'm Young. I'm one of the EMI4s. I'm going to be doing a lecture on pressure injuries and just like wounds from the nursing home. So, who's been feeling like this these past couple of days? I'm sure, people are overwhelmed with, oh yeah, I see Danielle over there. There you go. So, there's a lot of people, there's a lot of patients to be seen, a lot of pressure as new seniors or interns coming into the job. So, this is what we're doing. We're doing it every day. A nurse comes up to you and then they're like, hey, we got a 100-year-old patient and it's just for you. So that's great. And you're hoping it's going to be, have a great interaction like this. They're just going to be like, hey, I just want a medication refill. You're an awesome doctor. You're the best. But most of the time, that's not the case, unfortunately. Usually you walk into something like this. They tell you they're from the nursing home. You got no HPI. They didn't even send the sheet. You have no idea why they're here. And it's sad. This is why I kind of chose this topic. It's uncomfortable whenever I think about this because there's a lot of neglect and there's people they can't advocate for themselves and they come in with all these sicknesses. And then on top of that, we kind of miss the wounds that they carry with them. So that's why I wanted to talk about it. Just some epidemiology. I don't want to go into the papers because apparently we have a limited time, but this is kind of the prevalence and between coming into the hospital and hospital acquired. So as you can see, there's a pretty wide range, but they did a study of like over 300,000 patients. So pretty good numbers. From the nursing home, it says 10 to 35%. Somehow I think it's higher for our population, but I can't speak to that. And I always used to hear DSSM as an intern. I was just like, what does that even mean? That's just a nursing home nearby. It's named after Dr. Susan Smith McKinney. Cool history point. She was like the third African-American doctor in the United States and the first in New York State. So there's a lot of history in Brooklyn, but I won't go too far into that. So just talking about the pathogenesis of how do we get these pressure injuries? You need your pressure, friction and moisture are part of it. But I think, what we kind of are a part of is just not caring. And there's the staff not caring or just not bothering to look or not bothering to, think about it. So these are the points where you can get pressure injuries. Mostly our patients are going to be supine on the top. And the most, we won't be able to see them when they're supine. No one flips them over or turns them. So those are the kind of obvious ones that we kind of miss. So what are the risk factors of getting these ulcers? So, I mean, a major thing is immobility. All these patients are super thin, malnutrition, they have reduced perfusion in their skin, they have sensory loss. And of course, another risk factor, again, is people just don't look or don't care. So just how do we describe these ulcers? And I think this is really important because the nurses always talk about it. They always come from nursing home. Just a general idea. So stage 1, as you can see in picture A, is just the skin's intact, but it's non-blanchable redness, and it doesn't go away even when you relieve the pressure. Stage 2 is a partial thickness with exposed dermis. Stage 3 is full thickness, and then maybe you can see some adipose tissue and the rolled edges, as you can see in picture C. Stage 4 is full thickness, and then you could directly palpate or see like fascia, muscle, tendons, bones. And of course, there may be infections in all these, but these are just the staging of them. And then the unstageable ones are the pretty particularly gnarly looking ones where it's just like they have a eschar over or necrotic formation over and you can't tell how deep it goes. So that's the staging we kind of commonly have heard about and talk about in our notation. But there's also the Braden scale. I learned about this in intern year, but as you can see, it's kind of a very more in-depth documentation. I've seen nurses do it, but I don't really know how much I can trust that score. But it's something to be aware of, and that's how sometimes we use that in our documentation. So how do we take care of these ulcers? I mean, the general care of taking these ulcers, I think people forget about, and it kind of is sad as well as, they can't advocate for themselves. So they could be in a lot of pain, but, we may not be addressing their pain. So it's really important to consider that when we're taking care of our patients. The thing we're really good at, I guess, sort of is treating infection. So we always, thinking about that when we see our patients. I don't know if you've been on NeuroStroke, they have like a little turn turtle sign above like the patient's bed, but they have that kind of order to make sure they redistribute the pressure. And of course, optimizing nutrition as we talked about before. And then the biggest thing for us personally, and just our team, is to make sure we actually take a look and make sure to understand the progression or the resolution of these ulcers. So, and just generally speaking as well, there's stage specific management. Stage 1, we just cover it for protection. Stage 2, it may need a little debridement, but addressing that kind of maintains and protects the wound environment. Stage 3 and 4 is going to require some debridement at some point. And then, of course, we're always thinking about infections in between all these things. And I know we had some questions actually during our kind of small group, when to call surgery and stuff like that, but I guess we can go into that in a bit. So the question we always get from the nurses that always come, there's a couple of questions, but one is, how bad is it? So things we're actually pretty decent at is like, judging, we want to treat the infection. We love giving antibiotics. So those are 3 main types, are like superficial, soft tissue, and osteomyelitis. Just going into the micro, I don't want to get into too deep, but as we're pretty well aware, there's staph, Enterobacter, there's Proteus and anaerobes. But there's some papers that they did to analyze the kind of the culture data from there. As far as superficial infections go, usually they just have some increased exudate. There's no like systemic signs of infection. There's no, so for these, people actually just use topical antiseptics like sulfadiazine, like iodine stuff and chlorhexidine. Topical antibiotics are usually not recommended in this scenario. As far as soft tissue infection goes, we all know what cellulitis, hopefully knows what it looks like. There's erythema, warmth, tenderness. And, there could be a big difference by seeing, there's some pictures of A and B is like the initial, and C and D is 6 weeks later after actually being treated for these infections. Of course, we're always looking out for systemic signs of infections to decide what kind of oral versus IV versus how long versus what organisms we're going to be dealing with. So another thing, what happens when a nurse comes to you and hands you a swab? They're like, oh, this person has a wound. It's actively draining. It's right there. Do you want to, take a swab with it? And hopefully data shows that we shouldn't be doing these things. So these swab cultures, we kind of want to do it because it's right there. It's some sort of data point. And we don't want to cause pain to the patient. So it's relatively easier to swab. It's according to literature, if you want to check for MRSA, that's only MRSA, that's a possibility to swab it. But most of the time you're getting, because of these swabs, patients are getting inadequate or unnecessarily broad coverage. So most of the time, the data showing is that it's going to be representing colonization rather than what they're infected with. And then they did another study that showed that 2/3 of surgical specimens grew entirely different bacterial species than the surface swabs. So infectious disease, future teams are going to have a difficult time with that data because they're not going to know how to interpret it, if it's colonization, if it's chronic, or it's an active infection. So we try to err on this, not doing those swab cultures. So then what do we do? We have our surgical colleagues. So they're the best type of biopsy. I mean, culture is from a tissue biopsy. So they're going to be doing their debridement most likely, and then probably taking the tissue, and then they're going to send it for analysis so that we have accurate microbiology data for that. There was also some other studies talking about needle aspirations of wounds. The data was pretty limited. It only had like 72 patients in one and 30 in the other. So not really that many patients in the study, but they had some correlation that it might be sensitive and specific, but not, the data is kind of weak. And I don't know if I would be willing to take a needle into something. If I'm going to go that far, I would probably consult surgery at that point. And then as far as for us, we talk about antibiotics a lot. There's mild cellulitis where we could, this is just from up to date, but it's just from orals using like Augmentin plus some MRSA coverage. For severe sepsis infections, we know we're going to go guns blazing, they're probably going to have, so they have some MRSA coverage and then some pseudomonal coverage and some anaerobic coverage in there. In ESBL patients, you could also consider meropenem. And then for osteo, is a different type, obviously another type of infection that we always consider. They recommend getting these types of labs, the CBC, ESR, CRP, and blood cultures, but these also can be negative in chronic infections. But it's good to have on board. These patients will typically need, usually in the ER, we get an X-ray, and then if there's clinical suspicion, we get an MRI, and then they're going to get like an ortho consult. So just speaking also in surgery as well, I think, I think the main points for learning would be, actually, sorry, I got ahead of myself, but learning points are looking at your patients. I know it's annoying and it takes time and you need other people to turn the patient, but I think it's something that, we could really take care of and prevent from getting infected. And staging it and actually stating the diagnosis in the ED is extremely helpful, because then the people on medicine know what to look for, and they could actually put a diagnosis. They could get the wound care nurses involved, whether it's emergent or not. They could put the consult in, and then if it's really severe, on the floors now, they actually have a section where you could actually write if they came in with an ulcer or they developed an ulcer on the bottom, and people just copy forward all that. So it's really bad. But if you mention that in your diagnosis in the ED, some people can take a look at that and be able, hopefully they'll turn the patient, make the diagnosis. And then if it's not emergent, they could get surgery to evaluate. It's a little touch and go in the ED. Like I think some people mentioned when we were talking outside about when to ask surgery to look at an ulcer and debride. It's going to be based on clinical presentation and how bad it looks like. But on the floor, at least, they have more time. They could talk to you, even if just being able to have someone with a surgical specialty to look at it and possibly biopsy will be really important in the future. And then, of course, they can optimize nutrition, redistribute pressure with the order sets that are available on the floors. And then like I said, we're good at identifying infections. We could continue to do that. Otherwise, as I mentioned before, with the wound care, surgery, and antibiotics, the other important point that I also want to mention is make sure the patient is not in pain, and treating the pain in for the patient, and taking the extra time to give a multimodal treatment plan for the patients in the future. So if there's any questions, these are our sources that I have.